When we put this project together a while ago, I was really hoping that we'd have somebody who could just encapsulate what it means to do social networks in health. So pleased when Bernice Pesca-Solido could come down from Indiana. Bernice has been working in this field for a while. She's worked in areas of social networks, mental health, distress, stigma. It's a remarkable body of work. Her paper in the when it was the gold issue of ASR on the centennial of the field, I think has been a touchstone that I open every one of my graduate seminars with, just because it's just such a perfect encapsulation of what networks are and why they're important. And she's now the co-director of one of the country's biggest and best and most promising network analysis centers at Indiana. And so the best that we can do is trying to swamp them out. I think we're going to get past here quite quickly. Just friendly, of course, purely. But it's my distinct pleasure to have Bernice Pesca-Solido here today to sort of wrap up the conference and tell us where we're going from next. So thank you very much.
Great. Okay, thank you. Yeah, I'm the cleanup hitter, or whatever that baseball analogy is. I wanted to start off by saying that there will be some continuity with the last talk. I will mention Iceland is one of the pristine examples of something. And secondly, that I do believe there are times when you need to not model everything, and you need to go off-road and step back and ask some basic questions. So what I'm going to do is actually go from very simplistic view of networks, I think, because it's kind of old school, and sort of tell you where we're going on this in terms of how we're thinking about health. I want to start out with a general claim, and that is that we know, I can sort of go ahead and go to this next slide where, like, did I get it? Yeah. Okay, we get it. Networks matter, right? What you probably don't know is that this is an explanation that has come up and disappeared and come up and disappeared and come up and disappeared about 3 times in the history of medicine, health and healthcare, I think is probably a better way to say it. So we get it, and these are, some of the papers that we know, and about chains of affection and all of these other things now. I think that the issue is really thinking that there are 3 different ways that you can study networks, and you need to understand this because there's so much we need to know. It's like we get it, and we finally other people get it, but there's so much we need to know. And I want to say that we're presently doing a book on egocentric networks, and most of my work is egocentric. But I sort of categorize networks in 3 ways in the research that needs to be done. The first is what I call network-inspired research. Now, this involves no modeling at all, in a sense. It involves a lot of thinking, and it involves a lot of either what we would call deep ethnography in sociology, or you would call shoe leather epidemiology, right? I apparently don't have the same opinion of epidemiologists as our last speaker. So, although, well, no, I'm not going to go there. Never mind. Okay. So, but the point is that, there's a fundamental question of meaning and process, where the only way we can get the ground truth is by people doing deep personal studies, right? And I call these network inspired because they often don't involve large number of cases or even a quantitative data collection. Okay, they might be mixed method, and I certainly, think that that's a really important way to go if you want to understand structure. You can't understand structure without understanding numbers, but you can't understand meaning without understanding sort of what's going on the ground. And I think one of the most famous, if social networks ever wins a Nobel Prize in economics, it probably will be Mark Granovetter for The Strength of Weak Ties. And if you've ever read that either the AJS article that he wrote or the book, you see it's basically network inspired. There really aren't any network data in there that we think of now, and that's important because one of the struggles that we're having at this point in time is trying to figure out what counts and what doesn't count anymore. And I have to say, I'm a very big proponent of this idea of network-inspired research being something we need to continue. Now, maybe I say that because I've been criticized a lot because I don't use what we call sociocentric data, or full or complete network data. I don't know what, Jim, what do you call it?
Complete network.
complete network data. See, there's even like a thing there, complete, as opposed to egocentric, incomplete network data. Okay. So we come up with, even partial is a little bit of a slam, but okay. But what we've come up with these terms: network inspired, egocentric, and sociocentric. Okay, so that the full range of those I think are really, really important. So so I think all of those are important. And so when you think about your research, you can think about it in any of those ways. And I would argue that in the next phase of science, we really have to think about teamwork in a way that we've never thought about it before. Now, maybe you in public health have, or medicine have, but those of us in social science, we still like to put on our monk robes and go into a library or a coffee shop and sit there by ourselves, you know. But I think in order to get a sense of the complete systems that surround health and healthcare, we're going to have to work with people who take different approaches. And so that's, I'm going to tell the story of the approach that we've worked on for a while. And it really starts with a fundamental idea when I was in graduate school. And I was in graduate school at a time when there were three dominant models of healthcare utilization or healthcare outcome. And probably you know these if you're in health, right? So there's the health belief model, right? If something is appropriate and you feel that you're at risk, then you're gonna go have that, you know, colonoscopy or mammogram, right? Okay, the other one was the socio-behavioral model, which came out of sociology, which focused on issues of access more than anything else, and need in a way that hadn't been done before. And then there's the theory of reason-action, which I have to say I've never quite gotten because I don't understand. If you know somebody's intentionality, that's the best predictor, but the key is really understanding what feeds into intentionality. But, you know, like I said, what do I know? But when I was in graduate school, I loved these models because for the first time, we had these elegant models. We had perfected survey design. So we were doing now national surveys of healthcare utilization. And I don't mean just the ones the government collects, which has, you know, very skeletal social science data on it, right? But, you know, like Ron Anderson studies out of the Center for Health Administration Studies, the University of Chicago, you know, really good, you know, meaty kind of social science data on utilization. And then we had these analytic techniques, you know, all of a sudden, you know, everybody, I mean, this is the point that I was sort of in graduate school, it was like the beginning of looking at like dichotomous models and people still arguing, well, you can use regression and it still doesn't give you a bad answer most of the time, but, you know, we're way past that. That's something that doesn't fly anymore. But I was very excited about these models because that's what I'm interested in. I'm interested in how do people respond to the onset of illness? What do they do? What happens to them when they go to treatment? What happens to them when they're back in the community? And do they live or die? I mean, it's very simple questions. And these models were very exciting. They're still, I think, the dominant models in public health and health services research. But, you know, after I was sort of, you know, blown over, impressed by them, I started saying to myself, I don't know anybody who makes their health decisions that way, right? Because think about it. So our last speaker was talking about, you know, he seemed to like rational choice models. So if I'm going to critique something, it won't be agent-based models, although it sort of is because I don't believe in rational choice models except in very particular cases, right? I mean, I don't think they're wrong, right? I just think they're a subset of the messy world that we live in. And that what I wanted to do was figure out a model that could embrace the messiness, the complexity, the sort of habits that we have that feed into our health and healthcare. Okay, so so I said, well, you know, and I thought about my own healthcare, which, you know, probably narcissistic, but I'm not a clinician, so I don't diagnose. But you know, I was thinking about it, and I said, well, what do I do? I mean, here I was, you know, in graduate school and supposedly all grown up, and you know, every time I had something, what is the first thing I did? You know, I called my mother and whined at her. You know, and so she would say something like, don't be stupid, go to the drugstore and get blah, blah, blah. And I go to the drugstore and get it. So I started thinking about the idea of networks. And this was a time when we saw, I would argue, the third rise of networks, when the Harvard School and the Chicago School were really sort of, you know, breaking through on some of the methodological issues. So I came up with this model called the network episode model, and the idea was twofold in terms of thinking about networks. The first was that I wanted to think about networks as an illness career, right? Not just thinking about, not just trying to explain, does a person go to a doctor or not in a year, right? Which again, what the kind of national government surveys look like. I wanted to understand from the time that there was something wrong to the time, they either got better or died. I wanted to know what happened to them. And so I started thinking about this and thinking that part of the problem with the way that we're thinking about healthcare utilization is that we're not thinking about it as a network process. Now, I don't mean this just in terms of influence or culture, the culture that we hang around with pushing us. I'll get to that in a minute. But this was more the idea that there are chains of network utilization that need to be reconsidered and reconceptualize the dependent variable. So the first thing that we did, and a lot of what I'll be telling you about, is not so much insight as stupidity in terms of our first field study, and we wanted to do everything, right? And we did, and it was horrendous in many ways, but it still makes the data set the most unique that exists in this area. So the first thing we did was we learned the first day in the field that you can't translate your theory into methods directly. Because if you did that, you would say, okay, tell me when this first started. And that was our pilot study. We went in and we were looking at individuals who were making their first major contact to the largest private and the largest public hospital in Indianapolis, right, for mental health problems. And we got stories like, yesterday I turned on the television and I saw something in the corner that was not what I thought it was. I mean, I knew it wasn't real, and so I just came here. To when I was 3 and my father took away my tricycle, and we went back to the drawing board and said, that is not the way to sort of get at these stories. So we came up with the story, or the question that worked, which is, how did you end up here? Okay? And the first thing that we did was we read all those stories, which ranged from about 3 pages to about 27 pages. And if you know anything about mental health, you could probably guess that the 27 pages were from people who had bipolar disorder, ended up being diagnosed with bipolar disorder because they had pressured speech. But anyway, we coded those into 3 different pathways. There were the pathways that were the rational choice pathways, that no matter how long it took them, if they said somewhere in their story that they made a choice, we said, okay, we're going to call that a rational choice story. Because you always bend over backwards to disprove your own hypothesis, right? So if we were in error, we put it in choice. The second was what we all know about in mental health, which is the use of coercion, right? So being picked up by the police, being put on a psychiatric hold, having your mother guilt you into going into therapy. Like, those are different forms of coercion, but they're all ones which are clear about resistance, right? They didn't want to go, they don't want to be there. And so there were stories that told that. And so choice was about just under 50% of the stories. And again, very loose definition of choice. Coercion was about a quarter of the cases came into care from being coerced, right? Either what we call legal coercion or non-legal coercion, hard coercion or soft coercion. And then about 33% were the most interesting. We stole the concept from political science. Charles Lindblom had developed a concept about how American social policy is made, and it's called muddling through. Like we react to crises and we kind of bounce off things. And about 33% of individuals told stories in which a lot of times they weren't even in the story. It was almost a story from a third person. And so those were different networks, sort of thinking about the utilization itself as a network. We reconceptualized the dependent variable. And then we went to the idea of what would we expect in terms of how those you talk to influence your care. And we didn't have to come up with a theory. In 1970, Elliot Fraxton wrote this brilliant book called The Profession of Medicine. And he had developed a network theory under like the beginning of that third rise, and it disappeared again in medicine, but where he said, it's the structure of networks times the content of networks, right? Because the number of networks that you have will determine how much push people are going to give you, right? But it's only the content that will tell you whether they're going to push you to medicine or away from medicine, right? And so we looked at our 3 pathways, and it was very interesting, and it was a real lesson for me in terms of teamwork and collaboration. Because I struggled mightily with our ethnographic researcher who had been trained by Irving Goffman, right, one of the major, sociologists, and he was not exactly a medical sociology, but he spent a year in St. Elizabeth's Hospital in Washington, and she had trained with him, and we had a devil of a time convincing her to take a story and make it a 1, 2, or 3. She just did not want to be boxed in, right? And I was like, just put down a number, right? And she would be like, no. But then she told me from her ethnographic reading that it was clear that black women were being coerced into care, right? And I was like, well, that's a question. That's not a, So we did the analysis, and it turned out, no, it wasn't black women at all. It was people with large numbers of networks that had bipolar disorder. And if you think about the nature of mania, where people think they hear better, think better, see better than everybody else when they're in a manic episode, then it makes perfect sense. Large networks can push you, and bipolar, you're going to resist, and so those are the people who are being coerced. And there were a lot of other studies that we did on this data set and a number of other data sets that proved enough that, that it did look like we were, that networks were going to be helpful in sort of getting us an understanding of utilization. But one of the parts of this study, I had to spend 9 months in these 2 psychiatric units, right? So every day I showed up. This will date me. I was the cigarette lady, all right? Because at the top of the hour, psychiatric units were the last place where they got rid of cigarettes because there's so much of a side effect of the medication that they didn't want to take away the cigarettes as well. So, and the tobacco companies, and I guess I'm in the right place to talk about that. The tobacco companies used to send these little 6-packs. They were like 6 cigarettes in a package. And if people didn't have their own cigarettes, they could come to the nurse's station and they could get a cigarette top of the hour. And so I became the cigarette lady because we were also doing a study of the staff, right? And of course, none of them wanted to talk to me because they were all afraid it was some kind of job evaluation. But eventually, and I was pregnant, and I have to tell you, ladies, that really helped. I don't know if it helped my baby being in all that smoke, but it certainly helped. Eventually, they felt bad for me, like, okay, we'll answer her survey. So anyway, so it became clear to me that the treatment system should not be thought of as it changes the trajectory of these dynamic systems, but rather it's a network in itself, right? And I followed that up by thinking about the issue of provider-based stigma, that which I never got such a terrible score from NIMH in my life to suggest that people in treatment systems might sometimes inappropriately or unconsciously be telling patients, misinformation or not giving them hope, right? But you saw a lot of that because, who did people in psychiatric units see? Under current conditions, they see the worst of the worst. They see the sickest people, and certainly in the charity hospital, they saw the poorest people and the sickest people. So they had quite a negative view. Some had quite a negative view of whether or not these people could recover. So it became clear to me that the networks that get established in the psychiatric unit and whether or not they are continuous when those people go back into the community were important. So we did this phase 2. And then after that, it just became like a mushroom. And I'll save that for later because that's sort of where we ended up. And that's where I'm going to end up with this talk, which is with the network-embedded symbiome and with Iceland, which I'll make sense of later. Okay, so let me see. I'm going in the wrong direction, I think. Yeah, definitely going in the wrong direction. Or do I have to start over? Now I'm totally confused. Okay, here comes poor Jim to my. I usually have a clicker,
Yeah,
I'm usually good
our
with that.
Jeff ran off with our clicker, so.
Oh, he did? The statistician?
No, the other guy he left before you started. So.
Oh, okay. I was doing a dissertation defense on the phone in the other room, so I didn't hear that one. So.
Oh, as we have a new clicker.
Look at that! Oh,
Telling you.
man. Okay.
Thanks
wow.
to David.
Okay.
Give it a second to register
It's
here.
got to register. There we go.
All right, awesome.
Okay.
David,
All
come
right.
to the rescue once again.
Okay. All right, so the network episode model had a number of very simple things that I have to explain, especially to people who were really wedded to rational choice theory. Because they would say things like, well, if people aren't rational, you believe they're irrational. That doesn't make any sense. And I'd be like, no, I believe that people are individual and pragmatic and fundamentally social. And therefore, this idea of talking to other people about your health is not always purposive in the sort of rational choice framework, right? And that what we want to do in thinking about how people respond to illness is to think about, the entire illness career and base it on the event of, getting sick and then following it through. So focus on the dynamics, focus on the episode, not the choice, and then focus on the pathway. Okay, and so, this research that we did, basically was able to provide some support for all of these notions. That, when illness exceeds a person's capacity to deal with it, that they turn to other people. Because there are things that you do almost by habit. Like if you're somebody who gets migraines, you probably, even without thinking about it, turn to, particular kinds of drugs or things that you do, go in a dark room or whatever. But when it exceeds your ability to handle it, just as humans, we reach out, okay? And so that these are dynamic social processes that create this career for individuals. And for some, it turns into a dying trajectory. For some, it turns into a chronic illness trajectory. For some, it's one and done, okay? And there's not one network that matters, right? And there are multiple kinds of networks that facilitate and constrain each other. And this is where it starts to get complicated, and I'm going to work through an empirical example for you. And then what I said, this other idea of structure times content. You just can't find out the number of networks that they have, or the social support tradition, which finds out primarily whether or not people are satisfied or get the help that they need. You have to bring those two things together if you want to understand what happens to individuals. Okay, so let me start with the beginning, the sort of fundamental theoretical plane that I use to sort of think about healthcare, but now I also, this actually comes from the research I do on the epidemiology of suicide. And those of you who are sociologists who took Durkheim, or forced to read Durkheim, right? This is basically a network representation of Durkheim's theory of suicide, right? He argues that there are two fundamental characteristics of social groups, right, that need to be considered. One is how much integration there is in your life, right? And that's love, care, and concern. Do you have people around you who care about you, that do these kinds of things? But the other that we tend to forget in healthcare, especially from the social support tradition, is how much people regulate you, right? How much they guide you, they push you, they make you do things you don't want to do, like, when you tell your kids to brush their teeth, right? That's regulation. And what Durkheim said was the best place to be in terms of society forming a safety net under you is to be here at the bottom of the fishbowl, or the bottom of the net. Think of it like a circus net that tightrope performers have under them, right? So that's where there's the most bounce, because the number of network ties that you have at this nadir is really moderate, right? So you have a moderate amount of integration, a moderate amount of regulation, and that kind of is where the bounce is greatest in the net. Yeah.
Sorry, what's the z-axis here? Like, what does height represent, or depth?
So depth represents it. So there isn't. Oh, let me see. Okay. So this represents integration, right? So no integration, too much integration. Okay. Front to back, right, is the level of regulation. So no regulation in your life, too much regulation in your life. The depth really it's dependent upon the case. There isn't any, it's not a mathematical function. We have tried to come up with a mathematical description of it. I'd love it if you could come up with one. We thought it maybe was a reverse Cantor set, but it's not. So I don't know what it is, but every time I meet a mathematician or somebody who knows a lot about statistics, I go, can you give me a mathematical equation for this? So anyway, so I can't answer your question, because in some societies it might be that there's a big difference between, like in a time of change, for example. If we look at this, let's look at anomie for an example. So the classic example for anomie is the crash of 1929. okay? When all of the rules, right, because regulation is about rules, when all of the rules for our economics flew out the window during the crash, a lot of men on Wall Street jumped out of windows because all of a sudden they had no regulation, they were normless, right? They had no guides for their life. Now, if you go to the other end of that, where you have a place where you're over-regulated, and when you read Durkheim, a lot of people miss this because he had a little footnote. This was in a little footnote where he said, well, the logical other point is fatalism, but it doesn't exist in modern society. Okay? Wrong. Okay, all you need to think of is, Jonestown. All you need to think of is, quite frankly, any place where there's been a school shooting. Because I think the underlying thing that's going on in school shooting is that there's only one way to be in those small communities. And when you're not in that sort of mold, then you're sort of over-regulated and you try to find a way to get out of it, okay? Now, egoism is what we think of when people don't have anybody who cares about them, right? And so, you think of the lonely person, you think of the elderly person who doesn't have any ties, or, and here again, you can see that the ties, which you might think of as ropes, right? That if somebody has a traumatic event that happens to them, or just chronic problem like loneliness or a disease that's chronic, and it has withered away at their social networks, the ties now are so far away that when they fall off of the balance of their life, they can't grab onto the ropes, okay? Whereas if they're altruistic, if they're in an altruistic social structure, what happens is that they're so tight that it forms a wall, and when they hit it, it shatters. And the example of that would be the saints, right? So their life did not matter, okay? Because what was more important was their devotion, say, to Christianity, right? And so they were willing to give up their lives, essentially, in suicidal, or being thrown to the lions is not exactly something people do by choice. And so you have this situation, okay? So if we think about this not as what a person has, but as the theoretical range of social structures that can exist, then we start to get an idea of ways to think about prediction. Lisa?
Just a quick clarifying question. What does the dark mean, the shading?
The shading means there that the networks have gotten so tight, so close together. So, if you read, there's a really wonderful book that really, helps get rid of this idea that fatalism only exists in pre-modern societies. It's called Cities on a Hill. And she goes over all of the different cults that have ended in tragedy. And what you see is that people join these because they're here or here, and they want to be more in the middle. But since they're countercultural groups, as soon as there is a threat from the outside, they get, in her words, clenched up like a fist.
Right. Overcorrect.
Right, they overcorrect, right? So that when Congressman Ryan, for example, went down to Guyana, to Jonestown, they saw that as a threat, out came the guns. Like before that, it was all peace and love and vegetables, right? And then after Congressman Ryan, they were like, okay, the fascists, which by the way are you and I, the fascists are going to come. And there are wonderful tapes, well there's horrible tapes, but of Jim Jones asking parents, what would you do when the fascists come? And one parent said, well, I would, I'd take my daughter's place. And he'd say, no, you want her to end up with the fascists? And they said, no, I would kill her, right? And so you have parents, who are there to have love and support for themselves and their family, all of a sudden under this situation of over-regulation, sort of moving to the idea of drinking the Kool-Aid and all that. So I had to explain to my students where drinking the Kool-Aid came from. They had no idea. They use it all the time, and I had to stop in class and say, do you know where that comes from? So anyway, so this is basically the predictive plane that we want to talk about. So the point that I made earlier, though, is that there isn't one network that people have. And so the first study I want to talk to you about is one that my colleague Bria Perry and I worked on, in which we looked at personal networks. And again, these are egocentric personal networks, okay? But what we're going to do is look at the effect of the whole network, and I don't mean that as sociocentric, I'll explain that in a minute, right? How the whole network that you have results in activating people who are going to help integrate you or regulate you during a time when you're feeling like you're getting sick. And then, so the first question is looking at activation, and the second question is how does that health discussion network affect your recovery? Okay? This is all using egocentric data. Okay? All right, so the idea behind this is that mental illness is a shock to the system, and I think a lot of different kinds of events that you can think of that people in health are interested in are shocks to the system, right? I don't mean to your biological system, I mean to your social system. Because what happens with mental illness in particular is you have these changes in cognitive ability, which increase your support needs and also decrease your ability to keep your networks together, right? There are also stigma and social rejection as soon as people find out that you may have a major depression or you have bipolar disorder. You know, they don't want to work closely next to you on the job. I mean, we know the rate in the United States is 60% of Americans say they do not want to work closely on the job next to somebody with a mental illness. The irony is they are, but they don't know it because people are afraid to disclose because of stigma, okay? They also tend to lose statuses and roles. There's a very famous lawyer, and I'm trying to remember her name, senior moment, Ellen Sachs. Okay, Ellen Sachs runs the Center for Mental Illness and Law at USC, and she was at Yale in law school when she started talking about in her study group whether or not everybody around her realized that that the law books had been written by people who were terrorists who were going to attack the law school. And when, very, very bright woman, but at the time that she had this episode of schizophrenia, she took a leave from law school, and they told her that they could find her a job at McDonald's. Okay, and now she's probably one of the preeminent spokespeople, and she runs the Center for Law and Mental Health at USC, and she's just unbelievably brilliant. But that's what happens. You know, people because of the stigma, they start losing their roles and statuses. Very high divorce rate among people with mental health problems, etc. But they can get new ties through the mental health system. So one of the things that we wanted to know was what happens to people. So what we did is we went to these two units, and they weren't units, they were hospitals, but and we wanted people who were first-timers, right? Because you can't know the networks of somebody who's had a chronic mental illness for 20 years. So we had to get people who are making their major first contact, face-to-face, in-depth interviews, 3 waves of data collection, oversampling of women is always, right? Average major age of onset of first-time mental illness is between 15 and 24, so some of these people had really delayed, and I think the average for mental health problems is about 9 years, 7 to 9 years, that people will report that they were having problems and then getting to care. Most of them were white, and they had about a high school education. And most were depressed. There were some with schizophrenia, and others had a mixture of things, including everything from borderline personality disorder to narcissistic personality disorder to adjustment disorder. Right? Okay. So what we wanted to do in the first question, which was to try to figure out how people decide who to talk to in the networks that exist around them, okay? Now, I started out by saying that, one of the reasons this data set is so unique is that we were so stupid when we collected the first time we went to the field. And what we did, and Jim and Lisa, don't faint on this, we had 12 name generators in this data set. Like no network person of any sophistication would have 12 name generators in their study, but we did. So, we did it in every sector of their life, their family, their work, voluntary organizations. And then we asked 2 important questions. One was, who do you talk to about important matters, which I'm sure the person who talked about egocentric talked about the general social survey. I don't know, did they talk about the Behrman and Parigi paper? This is why I say meaning is important, because one of the reasons you want to ask the important matters question is because we have national norms. And so you can see whether or not the data that you're collecting is close to the national norms. The problem is that when Peter Behrman and Paolo Parigi did a follow-up study to that, which was quantitative, but was really, really in-depth, the name of their article is called Cloning Headless Frogs and Other Something or Others. Because when you ask people, what do you mean when what did you talk about with these people? And they came up with all these things that nobody expected. A lot of it was about relationships, so that was good. But there were all kinds of other things as well, okay? And so we asked that, but then, we had this sense that maybe we didn't know. We didn't know whether or not those networks were the same as their health networks. And I think people had assumed before then that health was so important, to us as researchers, that we assume everybody, it's so important to everybody. All you have to do is talk to a teenager and you know that they don't think health is important at all, right? Because they're invulnerable at that point, they believe. So we asked, who do you talk to about health matters, right? And then we did something else that was unusual, again, because we were too dumb to know any better. We asked, who do you talk to about, when you have health problems? And then we asked them, who talks to you, which I'm not going to talk about in this study. But then we asked them, is there anybody around who hassles you about your health and is always, that turned out to be, we call it the hassle network, but it's really the regulation network, right? And so the first thing that we did was try to understand how people activated who in that big network, like you put all those people together from those 12 name generators, who did they activate in that for their health problems? And then we tried to look at, how those health networks affected, how integration in particular affects what happens to people in the long run. And then we looked at these hassle networks and saw to see if we got anything different in terms of how networks are activated or who's in those networks and what kind of effects they have. Okay, so here are the network characteristics. Not that interesting, but you can see more people report supporters, 3.6 on average, rather than people who hassle them, 1.6. This is one of the early things I learned in network research was that I was told don't ask negative questions because you will kill rapport. So I told you that I was in those psychiatric units for 9 months. I can't tell you, their favorite question on the entire survey was, because these were staff networks, okay, who do you dislike on this unit? Right? And one of the most interesting things was, they would say to me, oh, everybody's going to say this person, right? No, it's really, there weren't any sort of, goblins, that they all pointed to. But they really enjoyed that because you have to be very clear about, privacy, confidentiality, all these other things. And that the networks that they were going to get back were going to be dots. They weren't going to be people. And so they were okay with that. And so you can see on average, if you add it up, on average they reported 12, 13, 14, about 16 people across these 12 things. So there was overlap, of course.
What leads to measure trust?
You know what? You saw how the egocentric networks are collected, right? So first thing, and I assume that this is the way it was told, first thing you collect all the names. Never collect a name and then go for the characteristics, because people are not stupid. Once they see that when you say, oh, John, and you ask 12 questions, and then you ask it again about Mary, the next time they go, I don't have any other friends. All right? So it's not unethical, but it is a trick. You must ask all the name generators first. And then maybe even at the end of the interview, go back and ask all the characteristics. So we just made up a question. I mean, one of the things I like about being a sociologist, and particularly a network sociologist, is that it's not that we don't care about reliability and validity, but a lot of it.
I prefer to say we're not stuck in other people's questions.
Well, no, I think it's even better. That the assumptions that were made under standard psychometrics do not fit network theory. So, for example, the PANIS, which is the measure of personality traits, right? That makes a lot of sense, because the idea is that you have your personality, and that's your personality. I don't know if that's true or not, I'm not a psychologist, but it's a trait. But if I ask you about your networks today, and then I go back and ask you about your networks in 2 weeks, I don't assume that they're going to be the same. I assume that they're dynamic, and they may change, and I'm going to want to know what happened in those 2 weeks that shook up your networks. Yeah?
So this profession, I fight with these name generators all the time. So did you, when you're asking the name generator questions, did you then you did all the name generator questions, like all 12 of them first, before you asked about anything?
No, and this may not be the right way to go, but what we did is we had domains of their life. And every time we went to a domain, we asked the name generator. And then at the end of the survey, we then got all the characteristics. And I want to make sure I answer your question.
So like all of the 12 name generators came before any interpreters were ever asked?
Before any interpreters were asked. Yeah. Wait, let me finish this. So what I was saying, and certainly Jim said it better, more professionally anyway, was that we just had you know how there's so many of these questions, and we probably had 12. And so this was like, how much does this person trust doctors? 1, 2, 3, right? So it was like a lot, somewhat, not. It's may not be the best measure, but can you imagine doing, a trust scale of another 6 questions there? You do lose people. I mean, like, people do get tired of us, so. And there was a question over here, yeah.
So did you say? Oh.
Yeah, it was you.
Did you say how long the survey took?
Well, that's complicated. I mean, if somebody could do it from beginning to end, probably took an hour and a half. But remember, these people were mostly hospitalized, so they were happy to see us. Not sad to see us, right? Number one. Let's see, number two, because of people's conditions, we often had to do it in segments because it was a combination of respondent burden but also cognitive vigor, I think, at the time. And I did things in this study that, if I had ever told Scott Long, who's like the methodologist in our department, he would have had a fit. Like it was clear to me being in the unit. And so if you want to collect close to 100% data when you're doing sociocentric data, you have to be a presence in people's lives, right? Like mine was guilt, right, in the pregnancy. That really helped me. But I could tell because I'm a sociologist. I use my tools. I was there for about a week and nobody would answer my survey. And I noticed there was this one staff person on the second unit. So there were 3 units in one hospital and 2 units in another hospital. And I could tell she was the ringleader. She was the absolute ringleader. And if I got her, I knew I would get everybody else, right? And she would not do the survey except with somebody else in the room. I did it. Okay, I did it. If I have to go to, survey research jail, I will go. And I loved it because they did not reinforce each other's answers. They would fight about their answers. No, this real place is really awful because we use some of Glisson's cultural content, the culture of the workplace measures. And they would argue with each other. I loved it. I mean, it taught me a lot about what was going on in that hospital. We ended up with a 97% response rate of 250 staff across the 2 hospital units. And myself and Eric Wright, who's at Georgia State now, we did all the interviews ourselves, right? And so we became known people to them. We just finished another staff survey in the neonatal intensive care unit at Children's Hospital. And again, I wasn't doing them this time. I've paid my dues on that. But I had a couple of graduate students, and they became part of the unit, and they got like an 88% response rate, and I can live with that. I don't know who else is working. I know Laura Cayley is working on trying to impute missing data from structure. So I'm okay with 88%, particularly in this kind of era of science, which I think there's a lot of non-progressive values out there regarding science and regarding what we do. So I'm very happy with that. Okay, so just give you a sense of what the networks look like, right? Okay.
So these are the statistics for the networks of the staff members.
No, these are the patients.
These are the patients. Okay.
These are the patients, and this is only the overall ones, right? Okay, now what I call this the usual and the not usual, or the not so usual, because almost all of research on networks or social support in health really focuses on this positive part. And so there is a huge literature on social networks, social support, having a confidant, Tony Antonucci's convoy model. I can rattle them on for about a half an hour of all these things that we have. Lisa Berkman's study of Alameda County, the classic study of social support and lower heart disease in Alameda County. So I call this the usual, and this is the question that we asked. This was the name generator. I'm interested in who you talk to about your health problems when they come up. Who are the people that you discuss your health with, or you can really count on when you have physical or emotional problems? Now, I know from a survey research perspective, anybody who is a strict survey researcher is going to say that's double-barreled, right? But I don't think I care. In terms of, we want to know who those supports are. We don't have the time, energy to sort of say, okay, who gives you money, who gives you emotional support, who gives you appraisal, the 4 dimensions of social support. So I can live with this. The thing is, who are the positive people you can go to for help? Okay? All right. And so the question that we're asking here is, what networks are activated as health networks from whole network, right? And here again, whole network here is really just all of the people that came out of the name generators, right? Okay, it's not whole in the sense of complete. Okay, this is still egocentric data. Okay, well the first effect is what I call the dummy effect, right? But it's an interesting effect, which says that there appears to be a limited number of people who get activated for health, no matter how big your network is, right? And so what this coefficient says, because it's an odds ratio, is that the larger the network size, the slightly smaller the number of networks in a number of people in your health discussion networks, right? And really, the way you translate that to make any sense is that people, no matter how big their networks are, they activate a limited number of people, okay? And this one says what you would hope for. People aren't. I spend a lot of my time, with researchers who think that the American public, is just not smart. But what do people do? They tend to activate those people in their network who trust physicians, right? So they go to who they think is the expert. And there was this wonderful study that I cannot find, but if anybody finds it, send me the link. I read it, but I read it as a review. I was reviewing it. It was a paper from Taiwan that showed that that really dug deeply into this idea of who do people activate in their health network. And they showed that even what we see as the most inappropriate choices for people, especially in lower classes, was the person that was most directly tied to the healthcare system that they knew. So, for example, it might be the janitor in the hospital, but that's where their social capital could take them, right? Okay, so basically there is a relationship, or there are, systematic ways that we activate our health networks from all of the people that we can judge from, okay? And then we were trying to figure out, how does this affect, say, satisfaction? I have to say, we looked at a whole bunch of measures. We looked at the GAF score, which I hate, by the way, if anybody, that's the Global Assessment of Functioning. But we had life satisfaction, continuity of care, looked at a whole bunch of outcomes, and the findings are basically the same, which is that the larger your network size, the more likely you are to be satisfied. The more close you are to people in your networks, the more likely you are, and that's a bigger, well, it's not a bigger effect because these are measured very differently. And then the more that you're talking to people who trust physicians, the better your outcomes are. Let me just show you, let me just move it to this so that you can see what it looks like. Okay, that's 2 of the 6 outcomes we looked at. Let me go back here and now go to Yusula. Yeah.
Did you look at the length of time since they were diagnosed as being influential at all and how their networks formed?
They were required, we had to get T1 within 3 weeks of them entering the hospital. What did their networks look like before is a really important question, like how much shrinkage might have occurred before that. I can't think of any way you can do that because even though it's a huge problem in terms of societal burden, if you would have to do a national study of like 100,000 people to end up with enough people to be able to know what their pre-networks look like. But let me tell you what we did instead. What we did is we did a survey sample of the city of Indianapolis, okay? And at 2 points in time, we asked them who they depend on, okay? So they were sort of our control, but it's loose control, okay? It turns out that what's interesting about this is that the networks of people with mental illness at T1 were actually more numerous than they were for the general population. But over time, the networks of the people in the population went up, right? And I think that's a learning effect, you know, like they were like, oh, now I know what you're trying to get from me. And I also thought of Susie, who I had thought of before. The networks of the people with mental illness shrunk, okay? But initially, they're higher than the general population. And that's something that was really kind of flew in the face of all the research that was out there about the shrunken networks of people with mental illness. And we have some papers on that if you're interested. Okay, so anyway, this just shows what they look like, right? So the more trust that, the greater trust you have in physicians, then the higher your life satisfaction. The network effects were all positive for integration in the right direction. Okay?
Bernice,
Yes, go ahead.
I have a question about the question that you had about people's trust in,
Right.
Like what types of people did they name? I'm just wondering, such that they could evaluate those individuals' trust in physicians.
That's a good question, and I have to say that, I'm not so sure that it was people who had the greatest medical expertise, but they're the people that they thought had the greatest expertise in the system.
Mm-hmm.
So they didn't go to people because, I have to tell you that we did a study in Puerto Rico after this, and the findings are exactly the opposite, right? Networks keep you out of care in Puerto Rico. They get you into care in the U.S. And that shouldn't be a surprise if you know anything about Puerto Rico, which is that in Puerto Rico, using the mental health system, which is under our Medicaid and has only first-generation psychoactive drugs for one, is not very well regarded. Not that anybody loves our mental health system either. But also in Puerto Rico, it's seen as a failure of the family, right? Where here we don't have that quite. If you think about the classic papers that I think is one of the great examples of network-inspired research is Charles Kadushin's 1966 paper called The Friends and Supporters of Psychotherapy, which he did a study of how people got into, I think at that time it was like psychoanalysis. And what he found was that, people went to their friends and they ended up going to the same therapist as their friends, right? And so we had this idea that networks get people into care, right? Then we go to Puerto Rico and we find the opposite, and we're like, wait a minute, we have to think through this, what's going on? Well, where did Charles Kadushin study? The Upper West Side of New York, right? Jerry Seinfeld and all his friends, right? They all had therapists, right? But in Puerto Rico, it's a very different cultural context, which supports that kind of Freitzen model of structure and content. Okay? Any other questions before I go on? Okay. All right. Okay, so now this is what people don't do. The only other person that has done this, and she comes out of the social support tradition and not the network tradition, is Deborah Amberson at University of Texas, Austin. I love her work, okay? Now, if I were to argue with Deb, it would be the following. She says that social networks are a subgroup of social support. I say social support is a subgroup of social networks. It's what, if you think of social networks as a large power grid, right? The wires are the networks, and then the content is what's zipping along that stuff. She sees that there's social support, and then it has a structure and these functions. But I don't know. As a network imperialist, I see it the other way. And so she has a piece with James House where she starts out by saying, social support is the big thing, and then social networks. I was like, oh no. So anyway, okay. So here's the regulation question, right? Who are the people who are always talking about your mental and physical health and trying to get you to do things about them? Is there anybody who tries to try to get you? These were probes afterwards. And people were like, well, what do you mean? Because just because we get our questions doesn't mean they get our questions, right? So like, is there anybody who tries to help you take your meds? Is there anybody who's always nagging you? And one of the interesting findings about this is that there is overlap, which I will show you in the end. There is overlap between people can be on the health network, the integration network, and the regulation network. Any guess who's the most likely person to be on both?
Your spouse.
Mom. Thank you. Now there's a good boy. There's a boy who knows, right? And so yeah, Mom was on both of them, for a lot of people. Okay. So what Deborah Amberson found in her research from a social support perspective is that one of the married men who have the best heart health are men who have wives that care about them but nag them, right? And you needed to have both to have better heart health, and that makes perfect sense because of the cultural tradition of gender and healthcare in our society, right? So it totally fits with the way we think about things. Okay. So here's how do they activate regulation networks from the ones that they have? Well, again, they have a limited number, okay? So just because your networks are bigger doesn't mean that you have more health regulators, okay? They tend to be people who are, they tend to pick the people who are very closest to them and not necessarily the people who are closest to them or the people with whom they have most frequent contact. And again, that goes to that idea that they're really searching for the expert, right? In their, because what your spouse probably knows, right? But what you know and what the person that you walk at the Y with, who happens to be a nurse, knows is much better. So people don't necessarily activate the people who are closest to us. And that, again, was sort of outside of the way people were thinking about networks. So that was kind of interesting. We haven't put, this is still, I'm still trying to finish writing this one up. But we found some interesting effects, because everybody's always saying, yeah, networks, but do they matter, right? Well, it turns out they matter a great deal. But in this case, what's really interesting about regulation, it's the closeness of the regulation combined with how big the network is that determines whether or not you have positive outcomes or negative outcomes, okay? So, and this is different than what we found with integration, right? Because what this says is that if you have the people who regulate you are not very close to you, the more people that nag you, the less satisfied you are, the worse your outcome is on a number of issues. But if these people are close to you and they're nagging you, then you have good outcomes, right? So, some stranger, I don't know, your dentist, tells you, you're not brushing your teeth, and that's the person that you have who nags you.
I just have a question about the life satisfaction measure.
Yeah.
Your choice of using it with people with mental health problems, and then is there pre and post measure? So is this the post measure?
Well, this is time two, right? Well, no, this one is not. I'm sorry. The first one was T2. This is not. This is actually cross-sectional. So, but that's the other thing. Like, when I went into these, the story of this is that I came up with this idea of network change and how people use their networks to get into healthcare. And I submitted a grant to the National Institute of Mental Health with sort of the skeleton of the network episode model and said I wanted to study individuals whose networks were changing. So I proposed college students for a number of very good reasons. One, their networks are fundamentally changing. This is a very high stress situation for many students. And the third thing is it's a major age of onset, okay? Well, NIMH, in its wisdom, came back to me, did not review the grant. What's that, DNR, right? Not do not resuscitate. sort of, do not review. They came back and they said, we really love, well, I didn't call them because I was so embarrassed, right? And so finally, Peggy Thoits, I don't know if you know her work, but Peggy Thoits comes into my office and she says, what happened to that grant? And I was like, it didn't get reviewed. And she's like, well, where is it? And I was like, well, fortunately, they weren't dumping our basket, so I could pull the review out of the basket. And she said, they want you to call them. And I'm like, what? They want you to call them. So I called them and said, we've been waiting to hear from you. And I was like, where does it say that, right? So the issue is persistence for those of you who are just starting out. But basically they said, we love what you're doing, but could you get real and study people with real mental health problems? I was like, okay, now we have a crisis in higher education, mental health, all right? Okay. I was there 20 years ago, but NIMH wasn't. But so then I ended up having to go to these psychiatric units, and I was afraid. I mean, I grew up in a society that is stigmatizing of people with mental illness. I was pregnant, so I was feeling vulnerable. I also think, well, maybe they couldn't answer the questions. I mean, yes, if there was somebody in an active episode, you didn't interview them. But basically, you know, when they were in an active episode, I mean, now I get opportunities to do all kinds of studies. We're doing a dental study, right? Networks, it will be the first study ever. So it's come late to dentistry, but it's there. My favorite people are studying people with mental health problems because they're very insightful. Many of them. They're not in psychiatry. So, yeah.
Yeah, I can hardly sit in my seat because I'm interested in people living with HIV/AIDS, which
Yes.
I'm sure you
Yes.
have 3 times
Yes.
higher mental health issues. But I was wondering if you were thinking about looking at experiential similarity with
Homophily? We did
well,
look at.
not necessarily homophily, but experiential similarity as defined by, I guess, Suter, who talks about not just being structurally similar.
No.
But okay.
Yes,
So,
absolutely.
Okay.
We call that experiential homophily.
Oh, okay.
So
Cool.
yes, so all I'm showing here is the multi-level effects,
Right.
like how the network affects individual outcomes. Because I wanted to show you that there are networks within that one network.
Right.
But yes, one of the strongest predictors on the individual level is experiential homophily. So the first person that they will contact the person that they know who has had the same problem.
Right. And
Right.
that support is.
Yes, absolutely
better.
critical for better
Yeah.
outcomes. Right. But this is just the cross-level effects. Yeah.
Sorry, it's a digression, but for people who are hearing voices, did you get some sense of the network structure of their voices?
No.
Okay.
No. Because, well, I don't know if you've read, Tanya Luhrmann's?
Yeah, that's exactly what
That's
I was
exactly what you were thinking of.
Yeah, like the cross-cultural comparisons.
Right, the cross-cultural
Yeah.
comparisons suggest that, that in America, we're told that our voices are bad and we should fight them, and our voices in America tend to be much more negative. But in countries like Ghana, and I forgot what the other country she was looking at.
I think it's India,
Okay.
where people.
Yes, and so people are told to not exactly make friends with their voices, but to talk back to them and acknowledge them and tell them, and they don't seem to have, although I worry a little bit about generalizability,
Right.
but it's like, because we just published a paper where we looked at the issue of whether or not people there's findings from the World Health Organization that people who live in developing societies have better outcomes than people in developed societies, right? And if any of you are in social work, psychology, and they taught you anything about cross-cultural, they've taught you about the international studies of schizophrenia, right? And this is like, so the head of the WHO mental health program says, if I had schizophrenia, I'd rather be in Nigeria than in Switzerland. And I read that and I'm like, no, seriously? So we actually did an 18-country study of stigma, and it's not true. It's not true. But they're not, it's not true in the sense that, yes, I don't question the WHO study for 1 minute, okay? But the textbooks tend to say the reason is stigma, right? That stigma is lower in places like India and Nigeria. And I was like, no. I mean, they still lock people up. They chain them to beds. And so they have mostly institutional care. Well, it turns out that the WHO findings, I think, in talking to Kim Hopper, who's an anthropologist, the reason I believe those studies is because of all of his analyses, which show that the WHO, the way that it works is that it does not give money for research. It sort of comes up with this idea, and then people from different countries can buy in. Well, it turns out that the clinic in India, in particular, that they bought into was a state-of-the-art wraparound clinic. And so, yes, if I had schizophrenia, I would want to be treated there than in most public mental health hospitals in the U.S. But as a society, I always say to my students, you all think like you wanted to live in the Camelot era, and I mean the real one, not the JFK one, right? You all wanted to live there, but face it, people, we're Americans, which means that you would have been peasants, right? And so, I don't want to go to India and be, have no treatment. And I don't know, do I think that treatment in the public mental health center is better than that? Yeah, I do. So I think you have to think about these cultural issues. And so I do worry a little bit about the generalizability of the Luhrmann findings,
Right.
but it's interesting to think about that we are so
Yeah.
captured by our view of mental illness.
Yeah, well, and the issue for me that was interesting was that in some of the other cultures where people were more family focused,
Yeah.
they were hearing voices of their family rather than final voices or voices of God. So the density of the network of their voices reflected the density of their support networks there.
Could.
Yeah.
It could. Yeah, I had a long time ago PhD student tell me, we were at the National Academy doing a report on stigma. It just came out April 20th. And he said to me, he goes, well, I hear you in my head all the time. And I kind of, but he's a wonderful, incredibly sane man. So, and so insightful as well, right? So anyway, so I wanted to show you this, that again, these things have different effects depending upon the kinds of networks. But all of these networks are considered to be personal level networks, okay? So even within networks, we have different levels. So like when you think of like if let's say you're going to do an organization, right? You want to think about the levels of networks that exist, and you can represent them in part by different name generators, like who do you hang out with, right? Who do you want to work with on your team, that kind of thing, because this structure is see this. Let me just show you this for a minute before I get into it. Oh, come on. I will get back to this. But this is a fractal structure, right? So this is self-replicating imagery of that one theoretical plane that I showed you before, that Durkheimian net, but it exists at all of these different levels. And what I was trying to show you today was we have so much work to do because mostly we've thought about this. But even within this level, what I've been showing you today is that there are at least two levels within this, right? The integration network and the regulation network, right? And there's an argument about whether or not, we should be looking at the neighborhood level of networks, or the, county level, or the state level, or the national level, right? So embedded within the geographic level, there are all kinds of networks as well. So this is just like an infinitely reproducing structure of all of the cross-cutting ties that people have. And you can have one network. This is why a safety net in the mental health system is so important. Because if this is weak, when people fall through here, they should be caught there. I know it should be the other way around to do that, but that's why it's really important. And that sort of refers to the paper that Jim was talking about, of why in pre-modern society they had such a strong safety net, was that all of the organizations, or you were in a certain family, which meant you had a certain occupation because you inherited it, which meant you were all in the same church, which meant you were all in the same village, right? And so the good side of that was that people didn't have a lot of, they didn't have a lot of stresses because they knew exactly their place in the world. But the downside of that was that they had if you were on the bad side of that network, you were really in trouble. And the other thing was that they had a real fear of and a real intolerance of strangers. So stigma was very high of outsiders. Yeah.
When you're thinking about, your multi-level approach to understanding personal networks,
Yes.
how have you been able to also represent organization and community in the same model? Because I'm just starting to think about, I work with organizations,
Yes.
right? And we know that organizations exist in communities,
Yes.
and, there's a lot of variation there.
Yep.
So when you start talking about building a model that represents all of these things, it starts looking like what you have on the screen there, and you have so many different levels of utility is,
Right.
is gone.
Well, I don't know.
Well, not.
But let me go back to this because that's where we're going to go now. Okay. All right. So let me go through the rest of this, and then we'll get to your question, which I think is really where networks is going. Okay. So we really need to go over that. All right. Now the paper that we're working on now is okay. So Durkheim's net is really about the intersection of health networks and integration and regulation networks. And so in our sample, we have about 14 There are about 400 ties that are integrated, 93 that are regulative, and 108 that are both, right? And so the paper that we're working on now is trying to understand that net per se and see where we go. But, you know, you hit all kinds of problems in terms of thinking about it, in terms of methods, and we'll get there sooner or later. So the insights of taking this kind of approach, I think, are twofold. The first is that you know, the benefits of social integration are influenced by the content. That's the trust measure. You ask one trust measure. I mean, if you ask one substantive measure about the health system, you need to ask them about trust, because that really is the fundamental thing that people care about. And then the other thing is that the relationship between social control, right, or the regulation networks depends on the strength of the ties. Whereas the power of the integrated networks doesn't matter how close they are, right? The second is that these two things these two aspects of networks may evolve differentially as a crisis unfolds. And one of the things that we found in another paper is that networks do shrink, but over time with people with mental health problems, but they shrink in a very rational way, which is the people who provide essential services stay in. Unfortunately or fortunately, those are mostly kin, and so the weaker ties fall away, okay? Now, the reason I say unfortunately is because that's how you get caregiver burnout, right? Because a lot of people who came at the beginning, well, what can I do to help? Can I bring you a casserole, right? They kind of disappear after a while, okay? And then, you know, and regulation, because we saw that in terms of, you know, if they had low closeness, more people were regulating them. That might be a response to perceived deficits in the integration network or the social support network. And that the access to resources may be contingent upon the norms of the network, right? And whether or not they're consistent with the way that the person is behaving, okay? All right, now, okay, the limitations, got to make sure you know them, like it's a treated sample, there's no information about people. That was one thing I loved about the Puerto Rico sample, was that it wasn't a treated sample, it was a population-based sample of the island. We don't know anything about the network's prior to entry, which somebody asked about, and it's small, it's pretty small, because it's intense to do this kind of thing, which goes to your question. But here's why we have to start thinking about it, okay? Because what Durkheim's net represents is really society, right? But sociologists have finally acknowledged that people have a body and a personality, okay? And maybe even genetics, So if we think about that, you know, as sort of the tightrope of their life, right, and they're balancing, and when they fall off, you know, it depends on where their social network is, whether or not they get supported, or they get lost, or they get smashed, right? But this, you know, the biomedical sciences have to be considered in this in some way. And this really follows from a series of findings or events that have happened, which is, you know, the Human Genome Project was supposed to open up the Book of Life, right? And the best thing that ever happened to social science was the Human Genome Project, because only 10% of diseases fit the simple Mendelian model. And most geneticists I know, not all of them, but most of them acknowledge the importance of, or the obsolescence of the nature versus nurture argument. Now some don't. Let me give you an example. Make sure I'm not running too late here. Okay, so I was sitting in this meeting and we were discussing a big study that they're going to do in Indiana, I hope, called the 10,000 Hoosiers Project. And it's very genetically based. And so I'm there and I'm like throwing myself on the floor saying, we need to do a representative sample of the state, not just the people in the biobank, right? The damn biobank. And so they were like, well, we don't understand. I mean, they literally, it was like the scene in Big. You seen the movie Big with Tom Hanks? Where, you know, that guy presents the toy and Tom Hanks is going, I don't get it. So all these geneticists are sitting there and they're looking at me and they're going, I don't get it. Can you give us an example? And so I say, okay, look, you know, one of the things we know is that white women get breast cancer, but black women die of breast cancer, right? Powerful example, right? Somebody from the other side of the room goes, that's because they have the XXX tumor. And the woman next to me who runs the biobank goes, and that's genetic. And I was like, damn. You know, I was like, oh my God. And I said, do you think that the only thing that happens to black women in this society is that they get a different kind of tumor? God help them, right? God help these women. But anyway, so, they are working on sequencing the XXX DNA so that they can, because they actually have had, I have to say, to give them credit, they have turned around some things incredibly in terms of finding the DNA of a tumor and then finding what will, I don't know what the word is because I don't know genetics that well, you know, that will, you know, stop the action of that, you know, RNA transfer or something. And there was this guy who was in like within 2 weeks of death, and they turned it around by doing something off-label. I mean, totally off-label, like not even something that was a medicine, right? But anyway, so I give them their credit. On the other hand, I do think we have a right to exist, and we have something to offer. And so, so this calls for the fact that we need a transdisciplinary response. And I mean that. I don't mean interdisciplinary. I mean people strong in their own disciplines sitting at the same table and being willing to give each other due respect and open ears, right? Okay. And this is what I think are the requirements for connecting models. The reason, I mean, we have tons of contextual models. Who can name a contextual model? No psychologist here? Okay. No, and public health uses it big time too.
Social cognitive.
Brofenbrenner circulars, right? There's the Brofenbrenner model. There's the one that they used in the Harvard breast cancer study, which I can't remember the name of. Social work has the PI model, individual person interacting with environment model. We have tons of these models. We know what the contexts are, okay? The problem is that there are hundreds of these models, and they do the first. They consider and articulate the full set of contextual models. But what they don't have is an engine of action, right? And they don't have an engine of action that speaks across disciplines, right? Network speaks across disciplines, from physics to molecular biology, right? So from the people who think that everything is a universal law to people who think it's all very individualistically based. Every one of those disciplines has a bigger or smaller group of people who take a network approach. Why that's important? It gives us a shared language. So we start off in a room with a shared language. Not that we don't have little fights about it, right? So for example, the other day, one of the computer scientists in my group said something about multiplex ties. And I went, and he said something, and I go, that's not a multiplex tie. And he said, yes it is. And I said, well, what do you mean by multiplexity? And he said, multi-level. And I said, multi-level is not multiplex. He goes, yes it is, we published it. And I said, like in 1972, Ron Burt, defined multiplexity as having a tie that has multiple purposes or functions, right? So they're either your friend and your churchgoer and whatever. We laugh about it, right? And that's what you have to do because there are these different histories, okay? So we offer an engine of action that connects levels, is dynamic. We can narrow down research questions so it doesn't become totally overwhelming, right? Because I was on the advisory board for the National Children's Study, which of course collapsed under its own weight. And part of the reason that it did is because everybody wanted their best measure of everything. And they had no way to sort of narrow down what they were going to ask and not ask. They had no way to do inclusion-exclusion criteria. And so it just became so impossible, they killed it, okay? Employ a metaphor and analytic language familiar to social and natural science. Got it, right? Understand the need for and full range of methodological tools. This is sort of my Joan of Arc mission, Qualitative network studies are important, okay? And provide a tangible way to intervene, right? We now know you don't tell somebody, go take your medications. You find the person in their network. This is what Laura Cayley is working on at the National Human Genome Research Institute. Map the network, find the person in the network who's most effective on that and intervene with that person and have them become, in essence, the guardian, right? Not the prison guard of, but the guardian of that network. And you probably in your own families, you know the person, right? You know the person that they should be talking to. like for better or worse, like do they have to convert them? Or can they just use them because they're already there, right? But that's the way to do that. So it really has this tripartite base, right? So we start from the social side with Granovetter's idea of social embeddedness. We're all connected, right? And then we come up with this, the notion of biological embeddedness, which is pretty new, because the idea of looking at the genome as a network hasn't quite taken off yet. But looking at the brain as a network has taken off, right? So they now call the brain the connectome, because what they're finding is that the invisible wiring of the brain seems to be more important in thinking about how to resolve mental illnesses or other brain disorders like epilepsy and Alzheimer's than understanding the structure of the brain. Because the first thing you learn in principles of psychopathology is that almost every brain disorder results in a shrunken frontal cortex, right? And it's always the same for brain chemicals, right? Norepinephrine, dopamine, serotonin, and epinephrine, right? And they all cause all these diseases, right? Because it's not really what the building blocks are, it's how they're connected, right? So, and then Clyde Hertzman, the anthropologist, public health person, came up with this idea of biological embedding, which is how society gets under the skin. And that's really one of the most interesting and important things that people are coming up with now, is talking about that. Okay, so the network embedded symbiome, it's also called the social symbiome, but I don't want to go through the history of how that happened. But anyway, it's the convergence or clash among network systems that drives the onset. So this is a model now that bridges epidemiology and health services and doesn't have this artificial line between how people get sick and what happens to them, because it is one person's life, right? It drives the onset and response to problems such as suicide, mental illness, substance abuse, right? And what we're arguing is that health behavior, and illness behavior, healthcare outcomes are shaped by 6 basic systems, 3 individual or internal, right, and 3 external systems. And these shape the dynamics and the recovery, the careers. And this is them. And again, because it's a fractal system, you can get very, like here, like at this level of health and human development identity, you can think about this simply as sociodemographics, right? You can think about it as personality. You can think about it as identity. I mean, those are all different kinds of networks. And there is research that's out there that is not in network terms, but is very network friendly. So for example, one of the main theories in sociological social psychology is identity theory by Shel Stryker. And when you read this, you can see the networks. But he actually he just passed away like 2 weeks ago. And he was like my academic daddy, So Shel, he thought like a network person. But when he was coming up with his theory, that language, he came out of a social, symbolic interaction perspective, right? And so he uses symbolic interaction language and comes up with things like commitment and salience, but they could easily be translated into network terms, right? So there's a whole way that you could do this, and he says that all of those things are what creates an individual's identity. The networks that people have, the choices they make about those networks create their identity. And then we can think about the connectome is not just one wiring system. They've discovered 3 wiring systems in the brain that overlay one another, right? And so this seems impossible, but Jim asked me to talk about where we're going, and I think this is where we're going. Now, it doesn't mean that everybody has to do every level, right? There's so much work that needs to be done at every level still, okay? But usually we're thinking about this dynamic pathway in combination with one of these levels, or maybe 2 of these levels, like the individual inside the organization, and how does that affect whether or not they engage in healthcare reform, right? I will say, and this is where I go back to the last talk, which is that this 10,000 Hoosier study is actually going to employ this framework. We're going to collect everything from genetic sequencing to GIS data on 4,000 to 10,000 Indiana. That is not the pristine example, though. I'm doing that because this is a presidential, meaning IU presidential, initiative. And so, you know, we have to do it for the sons and daughters of Indiana because we're a state school. But the other thing that we're doing, and we don't have the money for this one yet, is that we're going to do this in Iceland. Okay? Why are we going to do it in Iceland? Well, one, we have access. It's an island, okay? Which means that you have, I know it's a global village, but you have contained networks. And we're going to do everybody in the population, which is, no, see, I mean, everybody's like, it's only 200,000 people, adults. We're not going to do kids, right? They already have sequenced 80,000 genomes in the decode data set, which is very famous. We've already done a pilot study based on the idea that the Icelandic Cancer Society every year issues 1/5 of women in Iceland a letter to come in for their Pap and mammogram. And because it's Iceland, they do, right? So they come in, and when they come in to do their Pap and mammogram, they are recruited into the study, and they do a social survey, and they give a blood draw. We have done a pilot study. We have 65% response rate of the entire female population of Iceland. So I don't know, you know, is it going to work? Is it not going to work? I mean, some people say, well, Iceland is great because, you know, you have a control on genetic heritage, right? And other people say, oh, it's terrible because it's not the United States. You know, that's what the NIH, we're afraid, is going to say. But if you go back to the history of networks, the early development of network methods in the 1970s was done, and I am not making any parallelism here except in method, that some of the early methods were developed on islands with primates, right? Because they could monitor the number of primates and get their exact, behavior by observation, not self-report. And so I'm very excited about the Iceland study. In fact, that's where I'm going next week, is to Iceland to see, to go over the pilot data with the people there. So I have a saying, which is if you're going to fail, you might as well fail big, right? So we're going to try this in Indiana. We're going to try it. We're going to try it in Iceland. And, we may get the broad brushes. And if it is at all promising, it'll take, decades and decades and decades to figure out all the pieces. And as I said, we need network research at every level over time using multiple methods. So that's where I think health research is going, because I do think that connectedness, the CDC says it's now the major thing affecting their accident and trauma branch. You have other groups. I'm trying to think of what the other groups are. You have other groups that have really bought into this network perspective, because the individual perspective has taken us as far as it's going to take us, right? And so this really is an exciting time to do networks in health. From this week that is an absolute pain in the ass to do networks compared to doing traditional either randomized clinical trials or doing traditional social surveys or lab surveys, right? Or lab studies. I mean, it is a whole other degree of difficulty, but I think that the cost is going to pay off for us in terms of understanding the human body and the conditions in which we live and die. So I'll answer any questions you have. That's it for me. Yes.
Background information. I'm not a sociologist.
That's okay.
So I have one
We're
comment.
accepting.
Maybe. One comment,
We'll
one
be once
question.
we're done with you.
That's right. You will be. You will be once we're done with you.
I'll be protected, right? So the first comment is I really appreciate the comment about the validity and reliability. I wish I knew it the first day, because now it connected. Because during these 5 days, I was like, huh? What? How can you do that? But now I understand. And then my question is, what would you do with the self-selected community? Because of technology, now you have those online communities. You like support group, right?
We have it here. We have our scholars from, we have our physicists that study social media. They actually call themselves computational social scientists, which rubs me a little bit the wrong way, but they've already, our physicist has already GIS'd the whole island of Iceland. Okay. And the physicists have already isolated all the tweets from people in Iceland. It's very easy to identify an Icelandic person because of their
Right.
naming conventions.
But my question is, are you going to use the traditional or the method that you presented, they presented this week, or there should be something else because of
Yeah.
the different?
So let's say, like, well, within here, you're going to be doing egocentric analysis, right? But their connections, say, to the hospital units, like in Iceland, they have 5 major medical registries, right? So you connect them to their electronic health records, and there are experts, Jim is probably one of them, but there are experts like Filippo Radicchi and Steve Borgatti who are doing multi-level network stuff, right? So those methods aren't quite where we need them to be, but they are working on them. So you will use a combination of things, and I think one thing that would be very exciting to me, for example, I think that what we're going to do is, I'm hoping we're going to limit the studies to brain disorders, but not just mental illness, because it looks like there's a lot of comorbidity of depression with just about every brain disorder, every physical disorder for that matter. But it looks like, let me give you an example. Okay, there are 2 literatures already out there that have been out there for at least 20 years, if not more, which is that, let's say with Alzheimer's disease, right? We have a whole literature on the genetics of Alzheimer's, right? And we know there's this APOE, and I don't know, there are tangles and whatever. There's a whole nother, and this is in the same journal, Gerontology. So you read the biological one and you see all this stuff on, if you read the social one, you see for 20 years there's been research that social networks slow the cognitive decline of people with Alzheimer's, right? Now in the middle, what people are just starting to do is the connectomics of people with no cognitive impairment, mild cognitive impairment, or dementia, okay? Okay, so at Indiana we have me who does social networks and Bria. We have Olaf Sporns who does connectomics, and we have Andy Sakin who does the genetics. We're writing a proposal to put those 3 layers together. Now, do we have the methods worked out to figure it all out at this point? No. But we've piloted the social networks within the Alzheimer's ADNI study. I don't know what that stands for, but so it's like, baby steps. And I think that that's going to be okay, because the baby steps, you can't jump fast into this. So, like I said, this might be a big failure, it may not be the way to go, but it seems like it's interesting. So we'll try it, see what happens. Yeah, might as well try it, right? I mean, there's a lot of debate about the Christakis stuff. Did you guys cover that this week? Like, I'm sorry, I think that Nicholas going into he didn't go. Sending one of his assistants into the basement to recode the face sheets of the Framingham Heart study was brilliant. I think it was brilliant, right? Other people are like, yeah, but it's like not representative data. And I'm like, yeah, it's like, yeah, really, if you thought of it, you think it was brilliant. So I think that was brilliant, right? I think there's a lot of data that can be repurposed as relational data. So even now, there are things that we can do taking data that exists. Any face sheet on any survey can be used that way. Now, nationally, maybe not.
Well, this is the beauty of Iceland, right?
Right.
We keep the face sheets, and in the Egocentric, also ask the last 4 digits of their friend's phone number or something minimally identifiable, and then we can match it for you later.
Oh, really? Well, we know, well, first of all, they all have identification numbers.
Well, if you can get that, better.
Oh, yeah, no, here's the problem. No, here's the biggest problem with Iceland. We have to tell them about human subjects protection. They're like, oh, yeah, you can have this. We're like, no. Wait a minute.
Right. Stop that.
I know. It's like, no. But, I mean, the real problem that we face in applying to NIH for the money, because the people in Iceland, the people who are the cancer researchers who started this, which is why the Icelandic Cancer Society is involved, they've been applying to the EU for money to do what they call the Saga study. You may or may not know it, but ever since I had this graduate student who was from Iceland, I have learned more about Iceland than Saga is one of the words that the Icelanders have contributed to the global lexicon. Saga is an Icelandic word that means story or history, right? And so their project is called the Saga Project, the history of Iceland, right? And so we have to tell them. We have to tell them, like, don't, NIH requires that you post data publicly. these data, when we collect them, which they're very excited about, are the property of the nation of Iceland. They are not the property of the NIH. And so I don't know how we're gonna negotiate that.
We can do it in that health, you can do it in that.
Well, Peter said he could dust it, but,
Yeah.
yeah. I don't know. Any other questions?